How to diagnose asthma, how to diagnose COPD. As I said, asthma patients have good days and bad days. Now, if you have an asthma patient on one of his bad days, shortness of breath, wheezes, cough, he's symptomatic. Now, your question is, are you asthmatic patient or are you COPD patient? So what to do? What to do for this patient? You go by the pre and post bronchodilation pulmonary function testing. Asthma patients, because they have reactive airway disease, they get very good improvement following bronchodilation. So asthma and reactive airway disease in general are confirmed with an increase in FEV1 of more than 12% post bronchodilation. If on the other hand, the asthmatic patient presents to you on one of his good days, and all what you get is just a story. The patient tells you, I get attacks of shortness of breath and wheezes and cough and tightness of chest. But how about today? I'm perfectly fine. You examine this patient, nothing is there. If you do pulmonary function testing even, he's going to be perfectly normal. This is one of his good days. Then how are you going to make sure that he has asthma? You have to provoke an asthmatic attack. You have to challenge this patient's airways. Let this patient inhale substance called methacholine. When normal persons inhale methacholine, they react normally to it. Nothing will happen. Their bronchi will not constrict. But when asthma patients inhale even small concentrations of this methacholine, because their airways have an underlying inflammation, their airways are hyperresponsive. So when they inhale small concentrations of methacholine, their airways will constrict. And what is the test that corresponds to airway constriction? Yes, FEV1. So their FEV1 will drop to less than 80% of the control value when they inhale methacholine. So the methacholine challenge test, it's an asthma provocation test using an acetylcholine-like substance that will lower their FEV1 by more than 20% only in reactive airway disease patients. COPD patients. What do you need to diagnose COPD patients? The X-ray will show what? Flattening of the diaphragm, elongated heart because their lungs get hyperinflated. The blood gases, we nickname it by the 50-50 rule. What's the meaning of that? What's the normal oxygen? It's more than 90. What's the normal carbon dioxide? It's less than 40. So in COPD patients, carbon dioxide will increase. This 40 will move towards the 50 and might even exceed it. And this oxygen, the more than 90, will decrease towards 50. So we nickname it the 50-50 blood gases. Carbon dioxide moves up towards 50. Oxygen moves down towards 50, and their pH is always low normal, very low normal towards the acidic side, and their bicarbonate is always elevated to compensate for the elevated carbon dioxide. The AKG might show signs of right axis deviation because of the right-sided strain and right ventricular hypertrophy. Their CBC will show increased hematocrit. Why is that? Because these patients are kind of chronically hypoxic. When you are chronically hypoxic, your kidney will sense that. And your kidney will release erythropoietin to stimulate your bone marrow to produce more red blood cells. Because the kidney thinks that you are hypoxic, so let's get more oxygen delivery. So let's stimulate the bone marrow to produce more of the oxygen delivery guys, which are the red blood cells. So COPD patients are usually polycythemic and they have increased hematocrit. As for the chemistry, as I said, you always get increased serum bicarbonate as a compensation of the elevated carbon dioxide. How about the pulmonary function tests in COPD patients? COPD patients, what do we have? Obstruction. What is the test that corresponds to obstruction? FEV1, always low in COPD patients. Forced vital capacity is also low in COPD patients. But what decreases more? It is the FEV1. So we get low FEV1 to FVC ratio. The ratio in COPD patients is always less than 0.7, less than 70%. On the other hand, the total lung capacity, because of this hyperinflation and barrel-shaped chest, the total lung capacity is increased. Always remember, these patients have no problem getting air in. these patients have problem getting air out. So they get air in easily all the time and they trap it in. So the total lung capacity is increased, but when it comes to expiration, FEV1, it's slow, they cannot get it out fast, and they cannot get it out completely, so the forced vital capacity is also low. So, to diagnose asthma, what do you need? You need symptoms and you do spirometry. To diagnose chronic bronchitis, what do you need? Just the symptoms, productive cough. To diagnose emphysema, what do you need? You need a radiographic evidence of lung destruction, like CT. To diagnose COPD, what do you need? You need spirometry, you need a ratio FEV1 to FVC less than 0.7 or less than 70%, and you need also a diagnosis of chronic bronchitis, which is productive cough, and a diagnosis of emphysema, which is radiographic evidence of lung destruction.